Welcome to ANP Live Studio. I'm your host, a registered nurse and anatomy and physiology instructor for advanced healthcare professionals. Today, we're going to explore diabetes mellitus. It's a condition with a single name, but as we'll see, it represents two profoundly different stories. We're going to look at how one problem, high blood sugar, can come from two completely separate pathological journeys, which leads to distinct challenges for our patients and, of course, different strategies for us as clinicians.
So here's our roadmap. We'll start with two very different patient presentations. Then we'll build up from normal physiology to see exactly where things go wrong. After that, we'll connect those cellular problems to the clinical signs we see. And finally, we'll understand the logic behind why we treat them so differently.
To really ground our discussion, let's start where it all matters, in the clinic. We're about to meet two people who both have high blood sugar, but as you're about to see, their stories could not be more different.
On one side, we have Leo. He's just a kid, and his situation is acute. It's alarming. The sudden weight loss, that intense thirst, and especially that fruity odor on his breath, these are all red flags for a metabolic crisis. Then, on the other side, we have Mr. Garcia. He's in for a routine checkup. His symptoms are subtle, easy to brush off, and they've been creeping up for months. His risk factors, like his age, his Pima Indian heritage, which we know has a higher genetic risk, and his obesity, well, they paint a completely different picture.
And this is really the core question for today, isn't it? The high blood sugar is just the symptom. It's the final outcome. To really understand what's going on, we need to hit rewind and take a look at the body's normal, really elegant system for managing glucose.
So before we can understand the disease, we have to really appreciate the healthy system that it disrupts. Let's do a quick review of how normal glucose homeostasis is supposed to work.
You know, the body's goal is always to be in a state of euglycemia, which is just a fancy way of saying normal blood glucose. It's a constant balancing act. When you're fasting, the liver is the main glucose producer, while your tissues are the consumers. Now, what's really important here is that the brain needs a steady glucose supply and doesn't need insulin to get it. But your muscle and fat cells, they absolutely need insulin's permission to take up that glucose. Insulin is the master regulator in this whole process. So, when you eat a meal, your blood glucose rises, and that signals the beta cells in your pancreas to release insulin. This insulin then travels to muscle and fat cells and binds to its receptor. It's like a key turning a lock. This unlocks a signaling process inside the cell that tells these little vesicles full of GLUT4 transporters to move up to the cell's surface. These transporters are basically the gateways that let glucose come in. At the exact same time, insulin is telling the liver, hey, stop making more glucose. This two-pronged attack is incredibly efficient at bringing your blood sugar right back down to normal.
Okay, so that's the healthy system. Now let's see where that finely tuned system breaks down. This is the critical point where the path diverges. We're about to go from one problem, hyperglycemia, to two very distinct diseases.
Let's really dig into this. In type 1, the core problem is a case of mistaken identity. The immune system, specifically the T cells, goes on the attack and systematically destroys the body's own insulin-producing beta cells. The factory is literally destroyed, and that leads to an absolute total lack of insulin. Now in type 2, the insulin is there, at least at the beginning, but the locks on the cell doors, those insulin receptors and the signals they send, are essentially broken. The cells become resistant. The pancreas tries to compensate, pumping out more and more insulin, but eventually the beta cells just get worn out and start to fail. This leads to a relative insulin deficiency.
At the molecular level, type 1 is a classic autoimmune disease. If you were to look at a pancreas from someone newly diagnosed, you'd see something called insulitis, immune cells infiltrating the islets of Langerhans. We can actually detect this autoimmune process in the blood by looking for specific autoantibodies, like GAD65. The end result is a total absence of insulin. And to make matters worse, the alpha cells, which make glucagon, also get dysregulated and secrete way too much, which drives blood sugar up even further. This quote right here perfectly captures the two-hit problem in type 2 diabetes. It's not just one thing going wrong, it's two. The cells don't listen to insulin properly, that's the resistance part, and over time, the pancreas just can't make enough insulin to overcome that resistance. So let's break that down a bit more. That impaired GLUT4 translocation just means the glucose gateways don't get to the cell surface like they should. The liver starts to ignore insulin's signal to stop producing glucose. And over time, the beta cells themselves get damaged by the chronically high levels of glucose and free fatty acids, a state we actually call glucotoxicity and lipotoxicity. It's this vicious cycle, often driven by factors like obesity, that leads to that progressive beta cell failure.
So now we can finally connect these events happening at the cellular level back to our patients, Leo and Mr. Garcia. How does an autoimmune attack lead to Leo's acute crisis, while cellular resistance results in Mr. Garcia's subtle, slow-burning symptoms?
This table really lays it all out. Leo's onset was rapid because once a critical number of beta cells are destroyed, the system just collapses. His weight loss is from catabolism. Without any insulin, his body is forced to break down fat and muscle for fuel. That severe thirst and urination comes from osmotic diuresis, where so much glucose spills into the urine that it pulls water out with it. And that uncontrolled fat breakdown produces ketones, leading to the life-threatening state of diabetic ketoacidosis, or DKA. Mr. Garcia's path is totally different. The onset is gradual because insulin resistance develops over many years. He's often obese, which is a key driver of that resistance. And because there is still some insulin floating around, it's just enough to prevent that massive ketone production. So his risk of DKA is much lower.
Okay, so given these very different pathways, our diagnostic approach has to be precise. We need to distinguish between them using lab work and a good understanding of the genetic factors at play.
This table is basically our clinical roadmap. Now, while age and body weight are classic clues, they can sometimes be misleading. The definitive tests are molecular. A C-peptide level, for instance, measures how much insulin the body is making on its own. In type 1, it's going to be very low or even undetectable. Testing for those autoantibodies confirms the autoimmune process. And from a genetic standpoint, type 1 has a strong link to specific HLA genes, while type 2 has a more complex polygenic inheritance but a very strong family history link. This clear difference in pathophysiology creates a really logical foundation for how we approach treatment. I mean, it makes sense, right? Because the underlying problem is different, the solution has to be different. And the treatment logic flows directly from what we've just discussed. For type 1, the insulin factory is closed for business, so the logic is simple and absolute. We have to replace the missing hormone. For type 2, the factory is still working, just not very well, and the target cells aren't listening. So our primary goals are to make those cells more sensitive to insulin and, if we need to, help the pancreas secrete it more effectively.
For our type 1 patients like Leo, the entire goal of treatment is to mimic how the body naturally releases insulin. The standard of care is what we call a basal bolus regimen. This involves a long-acting insulin for background needs and a rapid-acting insulin for meals. Insulin pumps can do this with even more precision. And continuous glucose monitors, or CGMs, are absolutely essential tools now for tracking glucose in real time. They are critical for helping prevent dangerous low blood sugar, which is always a risk with insulin replacement. For our type 2 patients like Mr. Garcia, the approach is more tiered. It always starts with lifestyle modification. Diet and exercise are foundational. The first-line medication is metformin, which works mainly by telling the liver to chill out on glucose production. The newer drug classes like GLP-1 agonists and SGLT2 inhibitors are real game changers. They not only help with blood sugar, but also promote weight loss and protect the cardiovascular and renal systems. Insulin is usually reserved for later in the disease, when the pancreas just can't keep up anymore. And it's so important to remember that diabetes isn't just a blood sugar problem. It's a systemic disease. Chronic hyperglycemia is toxic to the body, especially to our blood vessels. It damages the delicate endothelial lining, which leads to all the long-term microvascular and macrovascular complications. This is exactly why we see such high rates of cardiovascular disease, kidney failure, and nerve damage. And if we think about our MRS includer systems, the lack of insulin's building effects also impacts the muscular and integumentary systems, leading to muscle wasting and that notoriously poor wound healing we see in these patients. All right, let's bring this all home and summarize the two very different paths of diabetes. We started with a state of normal glucose control. Then we saw that critical split, an autoimmune attack causing absolute insulin deficiency in type 1 versus cellular resistance and eventual beta cell failure in type 2. This fundamental split creates two completely different clinical journeys for our patients, which in turn demands two very distinct, logically tailored treatment strategies. By really understanding this entire cascade, all the way from the cell to the clinic, we can provide the best possible care for our patients. Stay patho-curious, and I'll see you in the next session. This A&P Live studio session is for educational purposes only and is not intended as medical advice.
Always consult with a qualified healthcare professional for diagnosis and treatment.